use of PD-L1 testing is really an emerging area in the care of patients with metastatic melanoma. Multiple studies have shown that patients that have a positive test for PD-L1 expression by immunohistochemistry seem to have better outcomes when treated with immunotherapy with anti-PD-1 antibodies. The place that we're really starting to look at the use of the PD-L1 antibody is in whether this helps to guide the decision to use single-agent PD-1 inhibitor therapy or combination therapy with anti-PD-1 and anti-CTLA-4. Probably the most compelling data that we have about the role of PD-L1 testing is from the CheckMate 067 study, a randomized phase 3 trial in which metastatic melanoma patients were treated with single-agent ipilimumab, single-agent nivolumab, or combined therapy with ipilimumab and nivolumab. Initial clinical results from the study demonstrated that the ipi-nivo combination had a very high response rate of almost 60%, but this was somewhat balanced by the fact it also had a very high rate of toxicity, with greater than 50% of patients having grade 3 or grade 4 toxicities. Single-agent PD-1 was also highly effective, with a response rate of approximately 45% and only 10% of patients experiencing grade 3 to grade 4 autoimmune toxicities. Patients treated with ipilimumab in this study had a response rate of approximately 20% and about 25% grade 3, grade 4 autoimmune toxicities. Both ipilimumab and the ipi-nivo combination had response rates that were much higher than were seen with ipilimumab alone, and each of those regimens in previous randomized clinical trials has shown superior response rate, safety, and overall survival compared to single-agent ipi. So on a day-to-day basis, physicians are left with the decision about whether to treat patients with single-agent PD-1 therapy or the ipi-nivo combination. In data that was recently reported at the 2017 AACR annual meeting, we finally heard the results of overall survival at 2 years for patients enrolled in this study. And this showed that overall, for patients with 2 years of follow-up, the overall survival rate with ipi-nivo was 64%, and with nivolumab alone, it was 59%. When the results were looked at separately in patients who were positive for PD-L1, the 2-year overall survival rates were actually nearly identical for single-agent nivo and the ipi-nivo combination. And in contrast, for patients who had a negative PD-L1 test, there actually seemed to be approximately a 10 to 11% improvement in overall survival at 2 years with the ipi-nivo combination compared to single-agent nivolumab. This suggests that the PD-L1 test may help to identify patients who get much more additive benefit from the ipi-nivo combination despite its increased toxicities. However, most of this data is really coming from a single study, and there's multiple PD-L1 tests that are available currently, and so this remains an area of research that will need to be studied further in the future. One of the key factors in guiding therapeutic selection for patients are their medical comorbidities, and indeed in this case we note this is a patient who had undergone a nephrectomy and has an elevated creatinine, consistent with impaired renal function. At this point in time, we still have very limited data available about the safety and use of most of our approved therapies in patients with abnormal organ function. And so this is an area where, again, we just monitor patients very closely. At this point, we really don't have any absolute contraindications to starting any of the available therapies in this patient. But certainly this is a patient where their renal function will have to be followed quite closely as they go through their therapy. So for patients who present with metastatic melanoma with the wild-type BRAF gene, at this point in time for patients who are eligible to receive it, the standard of care remains FDA-approved immune therapies. While again, these new therapies represent a tremendous advance over previously existing therapies, we do also consider enrollment in clinical trials for these patients, as to date we have no therapy that is 100% effective in all patients. In addition, we also consider clinical trials for patients who failed standard therapies in the second and third line setting,